So let me pin you down. So just on the RAS piece, testing today, you're doing RAS, extended RAS testing. BRAF, yes?
BRAF is done for research and or for routine in big cancer centers.
Yeah.
Is
for
not
prognosis.
Is done also because big cancer centers you can have also clinical trials running to find the best treatment options. But here there is not the same opinion in Europe. Some will treat with chemotherapy plus anti-EGFR also a BRAF mutant patients at least in first line. Some will not do it. I belong more to the second group, and for sure in third or fourth line of treatment, if the patient has a BRAF mutant tumor, you will not treat with anti-EGFR drugs, at least in later lines of treatment. But these are, conflicting with the data we had, and there will be presented also an update here at ASCO of the triple combination of anti-EGFR monoclonal antibody, anti-MEK inhibitor, so MEK inhibitor, and anti-mutated BRAF inhibitor, that the triple combination shows a very promising efficacy or activity, I
would say not very promising. I would say some activity, but where we had seen none before. It's not like we're seeing.
But what you get with chemotherapy is maybe 10% response rate.
This was better than that.
It was better than that.
Yeah. Same testing, BRAF?
Yeah, I think I'm tending to increasingly use the BRAF testing. I was a bit conservative and say how to use a prognostic information, which is only prognostic information, and the patient has the right not to know about his dismal prognosis. However, we learned today, and also we see some abstracts here, that patients have really poor prognosis also related to the fact that they very rarely get second-line chemotherapy. So having the information of a BRAF mutant patient means it is a good idea to give every treatment we would like to give to the patient up front. So give the patient the most active treatment because he has a relatively small likelihood that we will get a second-line treatment or even a third-line treatment. So therefore, I tend to implement BRAF testing more and more in my clinical routine. And we were also discussing this within the ESMO Guideline Committee last December at the meeting. And we are about to recommend this in the next version of the ESMO consensus, that we should have the information also
because
on the BRAF.
basically, if you want to be very schematic, you have two extremes. One is the RAS wild-type patient, the other one is the BRAF mutant patient. In the BRAF mutant patient, I totally agree with Dirk, you have to use all weapons you have up front, because maybe you have no time for anything else after. In the RAS wild-type patient, especially if the disease is less aggressive clinically, maybe you will have 2 or maybe 3 or even 4 lines of treatment.
So
you
just
can
made
make
the
a
argument that we should be testing BRAF in everybody. Because you would change your frontline chemotherapy choice.
Basically, what you do in practice in any center in Europe, you do a stepwise approach. So if exon 2 of KRAS, this is most frequently mutated, is wild type,
then you do subsequent.
And then if you have everything that is wild type for RAS genes, then you test BRAF.
So I want to come back to
you test much less patients.
What is your idea about BRAF testing from the US perspective?
I think it's done, and I don't really know what to do with it. I think I share your all's feelings. I'm not so convinced that all BRAFs need intensive therapy. I still believe that BRAF in the context of MSI may matter, that not BRAF MSS is bad, MSI BRAF may not be so bad. And
how many of these patients are in a metastatic setting?
So that's the question, is this really an early stage kind of thing, which I do want to cover in terms of molecular testing, the other side we started with, and that is mismatch repair and MSI. So we have both the inherited group and we have the acquired group. Totals, I don't know, people argue 15–20% of all of colorectal cancer. You mentioned the immune therapy thing. We'll come back to that. We, mostly in the United States, use it for stage 2s. I've been testing it in pretty much everybody because it's sort of a poor man's version of Lynch testing, HNPCC testing, and maybe, just maybe, there'll be some clinical trials. Phase in stage 3, some new data looking at MSI testing and outcome of adjuvant chemotherapy being presented tomorrow.
Well, I think MSI is increasingly important. We know about the prognostic role, we know about the potential predictive role for adjuvant treatment. We never believed that strong that there is a predictive role for adjuvant treatment and the benefit of 5FU on the European side.
So that it's not a negative.
For my interpretation, is clearly not a negative.
Okay, so it's not necessarily a positive. Either way, your prognosis is a little better, but chemo doesn't hurt.
Absolutely. And we also learned that we should use this information, as you just mentioned, in stage 4 disease. So for me, this is an example of a biomarker which is again and again revisited. And the information in metastatic disease is mainly more relevant to determine the, let's say, the access to immunotherapy. So open book for...
Are your Italian patients getting tested? I mean, are you all doing it routinely, metastatic?
This is done only in selected research cancer centers. It's not done for practice in every hospital. And there is also another word of caution, because when you use for practice in routine several gene testing, whatever they are, from gene mutation, gene expression profile, FISH, or immunohistochemistry, you are increasing the risk of errors, because if you have to standardize just one test, then you have to standardize 4, 5, 6 tests, and the risk of accumulating, false informations is really heavy. So therefore, in practice, we should use tests that are really useful for today clinical practice. What is useful for clinical research will be very important and should be defined first in exploratory way to be confirmed in clinical trials, and then you have to confirm in a validated biomarker assay.
So I think I may know the answer to this question, but I'm beginning to embrace, broad profiling, big next-gen sequencing, even IHC, FISH, and SISH for metastatic cancers to try and learn. And when we start looking at the cost of doing RAS and RAF testing and then MSI, and what it costs to bundle and do it all, it's starting to get equal. And
you're right, but this is another reason why either we do a shift in the way we treat cancer patients. It means, at least in small country sizes like in Europe, you centralize in comprehensive cancer centers the bulk of patients, and so they can get the best critical mass of experts in any aspects of diagnostic procedures, from imaging to molecular diagnosis. So you can offer to them high quality standards, or will be almost impossible. You can offer with the same quality prospective testings for clinical practice to all patients seen in all hospitals. And you have to consider also that a lot of private sources are offering these, and if there is not an external quality scheme that in some way validates the results, we always face a patient that comes with a lot of information through the web, with a list of genes that are changed in his tumor, comes to you and tells you what they have to do with it. And this is not the best we can do for our patients. So the path to personalization, individualization of treatment is still very complex. It should go with a very human interaction between patient and doctor, and the doctor should take the responsibility of saying, I think that this test should be done now, or you should do this test there.
If you were the health minister in Germany, and they asked, you're looking at the budget, and you had to decide between some new targeted therapy with a 1.4-month improvement in survival, or broad profiling between every patient with cancer, which would you pick?
Well, broad profiling makes treatment better, but not necessarily cheaper.
Yeah.
So I think if you see the promising data or the interesting data for the double inhibition of HER2 in those less than 5% of patients which express or amplify the HER2 receptor and the use of the double antibodies, this is highly efficacious for these patients, but not necessarily cost-saving.
Yeah, no, I can expand on that, because this was an Italian trial that started with an observation done by Alberto Bardelli in Turin, Livio Trusolino there, and Salvatore Siena in Milan, and they did patient-derived xenografts in which they found that in patients that were RAS wild type, they were initially responding to EGFR inhibitors, or they were badly responding to EGFR inhibitors. Some of these patients had a tumor with the HER2 gene amplification. Originally, they thought that this would be a much more frequent phenomenon. The reality is it's about 5% of KRAS exon 2 wild-type patients. So it's a small minority. But I can tell you about some patients that I have been treating that changed their lives. So basically, you need this kind of trials showing which is a relevant target, and then maybe a truly HER2 amplified colorectal cancer is a tumor in which HER2 is the real driver.
Right.
So like ALK4 gene rearrangement or other mutation in lung cancer.
Well, one of the abstracts actually does look at colon cancer
right.
HER2 positive with a response rate. And
right.
just what we needed is at least some patients responding.
Double anti-HER treatment, not cost saving, but efficacious.
Yeah, I mean, we had a molecular tumor board the other day where we had a colon cancer patient with HER2 positivity, and we were fortunate to have some breast cancer experts in the room to teach us what we should be doing, and then of course fighting with the agencies to get that approved and covered is the next side of that battle.
In gastric cancer, maybe it's about 15%, and so it's not so higher in terms of percentage.
Okay, well, let's talk.